And that is the end of my section. I will turn it over to Cicely to talk to you about supervision.
Where are we at? We're going to take a minute and do some questions. We've gotten a lot since the last time, so so if you just give us 1 second. Okay. This is me. Cicely stated that psychotherapy is not allowable for place of service 99. The most recent manual indicates that place of service is allowable for psychotherapy. It says that place of service 99 is allowable for 90832 with the UT modifier. So it's allowable when you're using it to represent crisis. But if you look, it doesn't allow it for any of the other psychotherapy codes. There seems to be an inconsistency regarding the pay reduction when operating under general supervision versus direct. The provider manual indicates that the supervisor is not included on the claim because it was not directly supervised. The claim will be paid at 72.25%, but I've heard you say it's 85%. Can you clarify? Yes. So if someone is under general supervision, it means they get 85% of their supervisor's rate. For someone under the general supervision of a licensed person, a licensed independent, that is 72.25% of the Medicaid max. So both are correct. So an LISW makes 85% of the Medicaid max. A social worker trainee under general supervision of an LISW makes 85% of their supervisor, which is 72.25% of the Medicaid max. If a TBS crisis occurs, can other services still be performed or billed for the same day, unlike psychotherapy for crisis? Yes, we don't have any limits on that as a state. Any NCCI edits that exist would still apply, but no, we don't. It doesn't have the same rules as psychotherapy for crisis. Can a licensed therapist conduct and bill for a QMHS group? So no, a licensed therapist cannot act as a QMHS. There are group options, mental health day treatment on the mental health side, and then SUD, IOP, and partial hospitalization, and individual group counseling on the SUD side. So I'm not sure if I answered that question correctly, but a licensed person cannot act as a QMHS. In crisis services, so you say CPST can provide crisis services to a client provided they personally know each other. I think you mean unlicensed staff can perform crisis services to a client that they personally know each other. We don't have anything called a CPST staff. Does this mean staff on the same team cannot provide crisis coverage for each other? What we mean is that the person, if they are unlicensed, has to be briefed on the patient's care. They cannot help someone who is off the street. So if you do a team method, if someone is covering, they need to be brought up to speed on that person's case. They need to have access to their case files. They need to be prepared to treat them because an unlicensed person doesn't have the capacity to assess someone on the fly. So this one's about hospital. Once again, if you have hospital questions, I'm going to refer you to our hospital staff. You can email hospital_policy@medicaid.ohio.gov, and they'll get that immediately and can answer any questions on hospital billing. I know that they also just posted their rate sheet on the website on medicaid.ohio.gov, so you can also look for that there. Can you clarify the meaning of place of service 53 CMHC? Many agencies seem confused whether they are 11 or 53. Well, that's kind of just an agency decision. 11 means office, and 53 means community mental health center. So either one, they're interchangeable if you're a provider type 84, so you can use either one. Yeah, I missed a couple. Can phone calls be billed under TBS or PSR, or is it face-to-face only? It is face-to-face only. All services are face-to-face only unless they're indicated that they are available by phone. So just assume that is face-to-face unless it says otherwise. Will a copy of this presentation be available? Yes, it will be posted. Does an unlicensed psychosocial rehab provider need to enroll with Medicaid if under the supervision? No unlicensed staff needs to be enrolled in Medicaid. We're actually going to talk about, or Mary already talked about?
Yeah.
Mary went through, I think this was asked before she did this. Mary went through all of the ones that need to enroll already, so just refer to those slides. Can you bill crisis services on the same day you bill day treatment? There are no state-defined limits on that. If there's an NCCI edit, obviously that wouldn't be allowed, but we don't have any edits against crisis and day treatment. Is the psychotherapy for crisis available for mental health providers as well as SUD? Yes, it's a shared code. Is there time limitations on crisis therapy? The state doesn't have any defined limits for crisis psychotherapy. However, I believe there is a NCCI edit and MUE currently. I'm going to talk about that in a little bit. So as long as that is still there, there will be a limitation placed by CMS and the AMA. H0048, urine testing and handling listed in the rule as not in residential setting. Does this apply to recovery house or sober living facilities and clients' homes? Residential facility, in the purpose of that rule, is referring to a substance use disorder residential treatment facility. That means that we will not separately reimburse for urine drug screen when someone is in a residential treatment because that's already included in the per diem rate. So all other allowable places of service for H0048 are found in the manual. Can mental health day treatment per diem be provided in a client's home or as a residential group setting? Once again, all allowable places of service are found in the manual.
Next question is, are agencies required to be certified in crisis services through Ohio MHAS in order to bill any crisis service? We have made some parallel rule changes on the MHAS side. Some are related to redesign. Some are finalizing the merger of ODATIS and ODMH. And yes, there is still a crisis certification rule out there that you will need to be certified under.
Okay, this is about who can provide case management and CPST in the Excel workbook. As I said earlier, the trainees and assistant cells got a little messed up, but once you get down, and we will post a new one, but once you get down to CPST, TBS, PSR, case management, they're operating under the their bachelor's or their master's degree, not necessarily their intern trainee. So if you look over and it says QMHS plus bachelor's, if your social worker trainee has a bachelor's, they can provide it. So we will fix the manual, but it's the same. We have not changed that policy on who can provide those services. CMS may do urine collection and handling, but not a QMHS, even though this is now available for mental health day treatment. No, urine drugs collection and handling is only available on the SUD side, and a QMHS is only on the mental health side. So that's correct. The workbook is correct. They cannot provide H0048. What other services can be billed on an IOP day? So you'll need to look at the rule. We just went through all of the IOP thing. The IOP per diem only includes group services. And now we've adjusted our policy to allow additional group services outside of it. So you can have all your individual services, all your medical services, and now some group services as well can be billed on the same day as an IOP day. It's not the same as it is now. If someone attends IOP for 2 days in a week and then misses a day due to illness, can IOP be billed for all 3 days? No, you only bill IOP for the days that they actually attended the IOP group. it doesn't mean that they are not in the IOP level of care if for some reason they miss a day, but you can't bill for the day that they miss. We already answered the crisis intervention. Hold on, I'm reading, so it takes me a second. So for, this is asking about our limit for psychiatric diagnostic evaluation. They are asking, we concerned with the 1 session limit on assessments. Currently, we often take 2 sessions for an assessment with children. You have a few options with that. 90791 is psychiatric diagnostic evaluation. I'm saying that because this is different than just an assessment. It's not the same service. They're not equivocal. So that is it's an encounter code. You get it for as long as it takes. So your option is to either just bill it for once for as long as it takes you to get all the information you need. Your other option is to request prior authorization for an additional unit of 90791 if you know it's medically necessary for it to take multiple times. And your third option is to complete what you need in a psychiatric diagnostic evaluation, bill it as 90791, and then as you're continuing to treat that patient, you can still get more information as your psychotherapy sessions or your counseling sessions continue. But 90791 is intended to cover a full psychiatric diagnostic evaluation, and it is generally not medically necessary for someone to have multiple psychiatric diagnostic evaluations in a year. Okay, yes. So if providing both mental health and SUD services, example, mental health psychotherapy and SUD case management, are these billed separately under the appropriate mental health and SUD services? Yes. So for Ohio Medicaid, you're seen as separate providers, even if you're under the same roof or you are a dual agency, or if the patient is has both a mental health and an SUD disorder. So you'll bill your mental health services under your mental health provider type 84 and your SUD services under your provider type 95. The copy of the manuals is on bh.medicaid.ohio.gov/manual. Are there time limitations for crisis psychotherapy? Just if applied by NCCI. Okay, so this is asking about hospital services again on the UB. So if you have any questions about how to bill on a UB, reach out to our hospital folks. So regarding TBS, can a practitioner who has associate's degree and has more than 3 years of experience be qualified as a QMHS plus 3 years of experience? Yes. If a client is new to us, receives a crisis psychotherapy service, and our crisis assessment includes all the items required in the brief assessment and treatment plan, can services then be provided CPST, PSR, TBS until they get their comprehensive assessment and full treatment plan? I believe the answer is yes. I'm a little unsure about providing a specific answer because I'm not sure exactly what the question is asking, but I think what you're referring to are the services that cannot be provided on the same day as crisis psychotherapy. So once the patient is been de-escalated, then yes, other services can be provided, such as CPST, TBS, and PSR. Okay.
All right. We're going to give Cicely a break here for a minute. We are just, we could probably stand here, sit here. Y'all can't see us, but run questions throughout the day. We're not even making a whole lot of headway. So if people would humor us, give us about 5 minutes to take a break in the room, then we're going to get back on the presentation and we'll come back to the questions as we can. Thank you.
Hello, everyone. All right, so we've done a very brief break. I'm going to jump in to the supervision requirements section. We'll tackle some more questions later, but once again, we want to make sure we get everything recorded and don't make y'all sit here till 5 o'clock tonight. Okay. All right, so we have two types of supervision. There is general supervision, where the supervising practitioner must be available by telephone to provide assistance and direction if needed. And then there's direct supervision, which is the supervising practitioner must be immediately available and interruptible to provide assistance and direction throughout the performance of the procedure. However, he or she does not need to be present in the room when the procedure is performed. So when we get to minimum supervision requirements, for CPT codes, it is all general, from your licensed professional counselor down to your trainees and assistants. This is a policy update that Doug was talking about earlier. So because we changed our policy and we had some practitioners that were prepared and were already operating under direct supervision, we did not want to kind of hinder the work that they had already done. So now we have this optional direct supervision for those of you who would like to use it. This means that if they are operating under that direct supervision definition and they're providing CPT codes for psychology assistants, interns, trainees, CDCAs, counselor trainees, social worker trainees, and marriage and family therapist trainees, they can also bill under direct supervision. And that means that the supervisor NPI does have to be on the claim, and then they make 100% of their supervisor rate. So I'll go into an example of that. So here's an example of the same practitioner providing the same service just under different levels of supervision. So for general supervision, a social worker trainee conducts a psychotherapy session with a patient with their supervising practitioner, an LISW, available by phone. The claim is going to be submitted with the U9 modifier that represents that social worker trainee credential. The rendering field will be blank. The billing field will contain the agency's MPI, and the supervisor field will be blank. MITS is going to adjudicate the claim using the social worker trainee rate, which is 85% of their supervisor's rate. So then, if they were operating under direct supervision, which means a social worker trainee conducts a psychotherapy session with a patient, and their supervisor, an LISW, is immediately available and interruptible if the social worker trainee needs direction while providing the session. The claim will be submitted with the U9 modifier again that represents the social worker trainee credential with the supervisor's NPI in the supervisor field. This allows us to be able to pay at the supervisor rate. Without that, we have no way of paying at that rate. So the rendering field will then be blank again. The billing field will contain the agency's MPI. The supervisor is taking responsibility for the service, and MITS will adjudicate the claim using the LISW rate. So the same, this has not changed. The supervisory requirements for HCPCS codes is general. Because it's always been general, and it's already within their scope, there are no direct supervision options for HCPCS codes. So a social worker trainee provides psychosocial rehabilitation to a patient with their homes, with their supervising practitioner available by phone. The claim will be submitted with the U9 modifier. The rendering field will be blank. The billing field will contain the agency's MPI, and the MITS is going to adjudicate the claim using the social worker trainee rate. Okay, so when we get down to it, reporting the supervisor on the claim, I wanted to take a second to make sure everybody understood how that is done. I'm skipping that slide. So let's ignore the slide previously because that is no longer accurate. So when you're reporting the supervisor on the claim, you're only going to report the supervisor on the claim if it's under direct supervision. This is the only time you should do that because that is the only time that we will be paying at the supervisor rate. Once the supervisor's MPI is in the claim, that indicates to us that we should pay off of that MPI, but it also indicates to us that they were under direct supervision. So if they were not operating under direct supervision and your medical record doesn't reflect that they were under direct supervision, do not put the MPI of the supervisor on the claim. In more specifics, you're going to report the supervising practitioner at the header level only, loop 2310D. Do not report the supervisor at the detail level, loop 2420D. You're going to need to report only one supervisor per claim at the header, because and then any detail lines under this header must have been directly supervised by this supervisor. And then on this claim, only report supervisors that are directly supervised by this practitioner. So that means that what you're going to do is, if you have John Smith, LISW, you're going to put his MPI in the header, and then every service that John Smith, LISW directly supervised are going to go at the detail line. Do not put any services that were supervised by a different LISW, and do not put any services that do not require direct supervision or were not provided under direct supervision. So here is an example of how to report this on the claim. So you see here, you have the supervisor MPI at the supervisor level, at the header level, no rendering, billing provider had the agency MPI. Then we get down here. You see that the modifier is U9, which means social worker trainee, and they provided psychotherapy for crisis add-on, and then I'm assuming a different social worker trainee it's a different date of service. Sorry. So then that social worker trainee on a different date of service provided psychotherapy for crisis. This means that U9 was always directly supervised by that supervisor MPI in the header. Do not report it this way. This is our big red X, incorrect reporting of a supervisor. So this means you put the supervisor MPI in the header, but underneath you put the correctly supervised ones under the U9, 1, 2, 3, but then on 4, you put a service that was provided by an LISW, which does not require direct supervision, and an RN, which does not require direct supervision, and this will cause this claim to not pay properly. Okay, so just to reiterate, you'll have to do a different header, a different claim for every different supervisor, and only report direct supervision. Do not report a supervisor for general supervision, because it will pay based on direct supervision, but your medical record will not match that payment, and it could result in having to recoup that payment. Okay, so when we talk about practitioner enrollment, just a reminder, these are all of the practitioners that we pay for in behavioral health, for community behavioral health. However, these are the ones that have to enroll. It's their physicians, your CNS, your CNP, physician assistant, RN, LPN, LISW, LPCC, LIMFT, LICDCs, and licensed psychologists. All of those practitioners need to be enrolled in Ohio Medicaid and then affiliated with your agency. They do not need to re-enroll as another physician. They just need to be enrolled and then affiliated with your agency. Physicians, all these ones can be affiliated with multiple agencies at the same time. There's a link to the MIDSPITS that tells you how to enroll and how to affiliate. So we always have this conversation. If they are not enrolled, how do they bill? So they're going to bill with a modifier, and you can see those options here. So a licensed professional counselor, every time they provide a service, they're going to use the U2 modifier to represent that they're an LPC. So this table was pulled right from the manual. It's been there, so this is how you know how these practitioners should bill. And then in addition, if any of these need to be combined or included with another modifier, you'll find that in the manual in this individual charts. So for example, some of them require both the U modifier plus one of the H modifiers to indicate an education level. A good example of that is a social worker trainee may be a bachelor's level or a master's level. So when you're billing, you're going to have to indicate which level they are for TBS. So just look at the manual, look at the charts to know which modifiers are required. Okay, so we have been, our staff here has been working on through any remaining backlog to prepare for July 1st. They've been working overtime to make sure that all these practitioners are enrolled. As of May 15th, we've had 175 agencies with no affiliated practitioners. We put remittance advice for all 84s and 95s. We sent out admittance bits, and we have a report of all the agencies without any affiliated. We have a report of the affiliated practitioners by agency on our website at this link. We've had some questions about this when you're reading it. Make sure you find your agency name and then look below your agency name to see your 84 and the enrollments and the 95s and the enrollments. It's not the number above your agency name, it's the number below your agency name. So I would recommend that everybody go look at that report, find your agency, and see how many are affiliated. As I said, as of now, 175 agencies have no affiliated practitioners. If they're not enrolled and affiliated by July 1, their claims will deny. So right now, as far as enrollment status as of May 10th, I'm not going to go through this entire chart, but you can take a look at it. It shows how many we have enrolled. Like we have, for example, we have 2,059 LISWs, provider type 37, enrolled. We have 12 in submit status, which means they have not been touched by Medicaid. And then we have 115 as of 2/27/2017 that were returned to provider that need more information. So make sure you're monitoring your inbox. If Medicaid has to return to provider and ask for more information or for clarification, please reply to that as soon as possible so we can make sure all these enrollments are processed for July 1. So I'm going to turn it over to Mary Haller.
So shall we do these few slides and then maybe respond to questions before lunch? Okay. So there's just a few slides here in my section, and then after I finish, we'll try and get through some of these questions. So I had said earlier that for any services that require prior authorization, you will be submitting those PA requests to MITS. And MITS already has a PA subsystem. You may not be familiar with it because you have not had to use it before now. Tomorrow we will be doing a webinar covering in great detail how to enter the MITS subsystem and how to enter in a prior authorization request and then upload documentation. This is, there are links on this slide that give you information about the existing PA training that is posted on the website. That's the PA functionality overview. And then there is also a webinar from previously. However, the webinar for tomorrow is going to be tailor-made for BH providers. You can go to our bh.medicaid.ohio.gov website and register for that training. And it will be held tomorrow by webinar between 1 and 3 in the afternoon. And there is the link to register for that webinar. We will be covering, we'll be focusing on ACT, IHBT, and SUD partial hospitalization because those are the services that will have to be prior authorized first since they require upfront PA before the service can be provided. So that's tomorrow. Okay, so let's take a break here and respond to some questions. I have no idea where we are. Okay. Why don't you take this one, Cicely? Sorry. Am I on it?
No, I just got to get a little closer. All right. So regarding the change to the tiered rates, if a service exceeds 90 minutes and some of the place of service is community and some of is office-based, will the whole time beyond 90 minutes be paid at 50% or will all be paid at 100%? Neither. 90 minutes in place of service, over 90 minutes in place of service office will be stepped on. 90 minutes in place of service community will not, so it's going to probably hit differently. We'll confirm that, but yeah, it's probably going to hit separately. What are the weekly maximum number of hours for partial hospitalization? So there are no maximum hours. Partial hospitalization level of care for SUD means that someone needs 20 or more hours of services per week. May a nurse do a health history prior to an MD or CNP first appointment without an order? RNs and LPNs cannot bill anything without a physician order. Can CPST multiple sessions be documented on same document? I'm a little unsure what the question means, but I would just refer you to our rules. 5160.805 lines out our documentation requirements. So I would refer you there for documentation. Can an RN or an LPN provide 96372 for therapeutic injection when a patient sees the psychiatrist for an E&M service on the same day in the office? I don't want to speak out of turn, so let me double check on that one. If an adult client is in an IOP level of care and only comes 2 days for 3 hours, is it billed as H0005 or H0015 if a client did not meet the minimum 9 hours? So if they are truly in the IOP level of care, you would bill it as IOP. We understand that sometimes a patient is going to miss services or things are going to come up where they have to cancel, and that is totally fine. It's just that if it becomes a pattern where you may need to adjust their level of care or adjust your billing as needed, when you bill H0015 to us, you are telling us that they are in the IOP level of care, and that is accurate even if they miss an appointment once in a while. Okay. Keep going. So for SUD group, if you co-facilitate a group of 18 patients, can you bill all 18 to a single therapist, or can you bill only 12? So you can bill all 18 to a single therapist. You would bill to the person with the highest credential in the room. However, if you are seeing 18 patients, it is required to then have 2 staff members co-facilitating that group because the maximum group size is 1 to 12. On the new diagnosis grouping documentation, gambling is only listed as a mental health. In the past, there have been different diagnoses available as it is frequently connected to the SUD co-occurring issue. Our diagnosis groups show the primary diagnoses that are allowable. Multiple diagnoses can be reported on a claim, but gambling is not a primary diagnosis for SUD. Okay. So do we use H005 if the minutes are 54 to 60 minutes, and then 90853 if it is less than 53 minutes? Yes. So you would use 90853 if it's less than an hour, and then once you get above that, you can use H0005.
Apologize if we're making noise. We're handing the microphone around. So if we attribute all of the members of an IOP group to the higher credentialed staff or co-facilitated group, does that impact the ratio? We have reiterated, and Cicely just said that, again, that anytime you have 13 patients, you have to have 2 clinicians. So that goes for every sequence of 12. So 13 requires 2 clinicians, 25 would require 3. You know, at that point, you're getting into very large groups, so you might not want to do that and use your staff a little differently. Group size, then you have a go. Yep, same question. If we maintain 12 to 1, can all clients? That's the same question. Clients in 2. Can an agency have clients in different levels of care in the same group? Yes, you may put patients in different levels of care in any group that they would benefit from. Can case management or individual counseling be billed with H0015? I'm assuming you mean the case management service or individual counseling or individual psychotherapy coded separately and billed on the same day as H0015. That is correct. If you're asking if you can put those in the H0015, you would not do that. Day treatment and SUD PH. We'll skip that. That's a managed care plan one. Yeah, we'll keep doing. Do both of these require SUD residential, acute detox, or outpatient in the residential setting, which I covered earlier? Do they require an MD or nurse practitioner note every day for them to be billed under the MD or NP? Some level of interaction would need to occur with those practitioners in order for them to be reported as the actual rendering. H0014, ambulatory detox, that's the registered nurse or licensed practical nurse. Do they require MD or NP sign-off? We don't require that in terms of note, but they do have to operate under a physician order, as Cicely has mentioned a couple of times. In 90839 and 90840, those are the crisis psychotherapy coding. Is the time spent in arranging a disposition for the patient included in the billable time? If you go back to the definition of those services, what is counted towards those codes is actually the face-to-face time with the patient. Do all injections, regardless of the medication, billed with the injection code 96372 require a drug code NDC, National Drug Code? Yes, you need to actually report the National Drug Code. And are we required to buy and store the medication associated with the billed injection code? It depends on the medication and whether it's covered as a pharmacy benefit or medical benefit. So that can vary. If a person is in residential SUD, then does this mean they cannot receive mental health services from a separate mental health provider and have them reimbursed? That is a change here. Yes, when an individual is in SUD residential, the staffing should be able to accommodate both conditions that the individual has. Question regarding IHBT prior authorization. Given that some IHBT episodes last several weeks or months, please provide the rationale for PA approval every 3 days. It's not a PA approval every 3 days. It's expediting the PA, and Mary will talk.
It's the 72-hour, I think is what you're referring to. That's 72 hours of service. So it's not 72 hours totaling 3 days. It means you can be prior auth for 72 hours of service.
So you kind of have to piece those together, the expediting of the PA, which lines up with the 3 days, and Cicely mentioned the total number of hours. Yep. So I understand that the software company responsible for the prior authorization program will not be ready by July 1. They actually will be ready by July 1, and that's part of why we're doing the webinar, to make sure that everybody understands we are still implementing July 1. There will be more in the PA webinar tomorrow, so please sign up for that. Skip that one for now.
Mental health outpatient 90791 prior authorization. Does this apply to children? Yes. So 90791 is psychiatric diagnostic assessment, and the policy applies to adults and children. It's prior authorization after you have reached a threshold of one encounter of 90791 and one encounter of 90792. At that point, you would need to seek prior authorization.
What is the doc? Okay. So, and then you ask about interactive complexity. So you cannot just apply interactive complexity to every appointment you have with someone. It has to be something that impacts the actual visit that day. So you can't just pick a patient and decide that they're likely interactively complex and then bill it every time. 90875 has in the workbook and in the manual all of the codes that it can be added to, so you can look there. And then 99354, the prolonged services, also have all the codes that it can be added to in the manual and in the workbook. Okay, so this is asking again about psychiatric diagnostic evaluation, and if you get one per billing agency, which means yes, you would get one for an 84 and one for a 95. However, a psychiatric diagnostic evaluation is not intended just to get the brief diagnosis that you need. When you are doing, and understood that you can ask prior authorization or a different agency can provide one, but it really is supposed to capture the entirety of that patient. So if you are a mental health provider and you are providing a psychiatric diagnostic evaluation, and you should be able to be asking about any SUD issues that they do have as well. So I wouldn't just send them straight over to your 95 to get another PDE if you can assess what they have on the first one. So limitations by client, by year, by provider. Does this mean individual service provider as an agency as a whole? No, this means an agency as a whole. So things like psychiatric diagnostic evaluation is one per billing provider, and the individual practitioners are not billing providers. Service benefits, will they be tracked in MITS? And is it approval based on first billed / adjudicated by ODM or dates of service? So we will track the benefits in MITS, and it is tracked by first in. So whichever is paid first is going to go towards the limit. How does Medicaid count E&M and other CPT codes towards level of care when these services are not timed but event-based? That information is in the workbook, how we calculate that. Okay, so this person says, I'm currently billing 6 units of H004 with the HQ modifier for mental health services, not SUD. Aside from 90853 for group, what is allowed? Okay, so on the mental health side for group services, you have 90853, which is group psychotherapy. You have your mental health day treatment, hourly and per diem. You have TBS group, you have CPST group, and you have RN services group. So there are many options. Is there a different reimbursement amount when crisis UT modifier are used? No, there is not. It's the same. For SUD IOP, if you meet the minimum 6 hours for children, can you bill for an additional services provided outside of the per diem, or do all hours 6 to 19.9 hours count in the per diem? The per diem is only group services, so everything else is billed outside. Can a CDCA provide TBS and PSR since they are only considered an assistant trainee and not a licensed professional? No, because they are a SUD provider, and TBS and PSR are mental health services. Okay, so this is asking about billing Medicare if the person, I'm assuming you mean an LPC, but the rendering supervisor is an LISW. So 2 things. You would never report the supervisor in the supervisor field for a service provided by an LPC because they do not have direct supervision as an option. Second, you would never put the supervisor MPI in the rendering field. And then 3, an LPC is one of the providers that can be billed directly to Medicaid because Medicare does not pay for them. So, and for the Medicare thing, it's in the slides, and we went over this earlier. So if the service is not covered by Medicare, you can bill it directly to Medicaid. We have a list on the website of services that must be billed to Medicare if they are provided by a Medicare eligible practitioner. Once again, we for Medicare, Medicaid purposes, we have all that information in the slides and on the manual and on the website.
All right, could you please clarify MCR Medicaid billing? If you do, whoops, I'm sorry, that's not the one I was reading. Please explain the approach Ohio MHAS is taking to certification for the Redesign services. We can't answer that directly. Our licensure and certification folks are working on that and are planning to release communication here shortly. The intent is to make sure that everybody gets across July 1st, so hopefully we will have something shared shortly on that.
Okay, is the third-party liability specific to the redesign that goes into effect 7/1, or is that true today for commercial denials that we can bill to Medicaid with the denial code? Where does the denial code need to go on the bill? So I believe today you're probably getting denials for third-party commercial liability. It depends. Yes, if you do get a denial from a commercial payer, they'll give you a denial code, and it's a service that is reimbursable by Medicaid, you can bill it to Medicaid. I don't know where the denial code goes on the bill. That's something that someone more IT-minded would have to help you with, but I'm sure your billing people know where it is. Has there been an addition of an LSW as a rendering provider under the billing Medicaid claims? No, they use a modifier. We've already talked about TPL. Once again, if it's a service that has to be billed to Medicare, that is listed on the website, you must bill it to a commercial, and they will give you a denial code, and then you put the denial code on the claim. If for some reason they will not even allow you to submit the claim, which will not happen for these types of codes. So things like CPT, right now you don't have any of those codes. That's probably why they're not even letting you bill them. But things like CPT will go through. If they don't pay for the practitioner, they will deny it. If for some reason they will not give you a denial code, you need to get documentation for them saying that they don't bill for that practitioner, or they don't bill for that provider. Okay. I think then it is now a little after 12. We need to take a lunch break. We can address some of the rest of the questions later. If we don't get them all, we will respond to you after the training. How long are we going to?
We will take a break for an hour. We will start back up promptly at 1 o'clock. So we'll put something up on the slideshow so that everybody will know we're on lunch break. So we will be back with you shortly. Thank you.
All right. Hope everybody is back from lunch. We're going to go ahead and get started so we can make sure we get through everything and then spend some time afterwards answering some questions. So I'm going to talk to you for a second about the National Correct Coding Initiative, NCCI. We've mentioned it a few times already today, and most of you are familiar with it, but just in case you are not. The National Correct Coding Initiative was required by the Affordable Care Act. It attempts to assure that practitioners are working within scope and control and proper coding. It's implemented, governed, and regulated by CMS, the Centers for Medicare and Medicaid. And providers should check NCCI quarterly updates and adjust your billing accordingly. There was one updated April 1st, which is the most recent one as of now, but they are updated every quarter. They will post the full list of edits in an Excel sheet, but then they also post a change document every quarter so you can see what has changed so you don't have to hunt for any updates. We implemented NCCI October 1st of 2010 for the rest of Ohio Medicaid program, but held behavioral health out. And now with the July 1 implementation of behavioral health redesign, we'll be implementing NCCI. So NCCI policies are applied as claim edits or denials. So there's two types. Procedure-to-procedure edits, which are pairs of codes that may not be reported together when delivered by the same practitioner to the same recipient on the same day. And then there's medically unlikely edits, which define the maximum number of units that can be billed by the same practitioner, same recipient, same day. So, PTP, procedure-to-procedure edits. There is a link there. That's where you're going to find all of these NCCI edits. Make sure that you click on the Medicaid edits, not the Medicare edits. So when you download this PTP edits form, there's either going to be a correct coding modifier indicator of 0 or 1. 0 means the codes can never be reported together by the same practitioner to the same patient on the same day. If they are reported on the same day, the column 1 will be the code that will pay, and the column 2 code will deny. So for PTP edits, I have a correct coding modifier indicator of 1. They can only be reported together in circumstances where they are completely separate and distinct, and they are an NCCI modifier is put on the claim to override that NCCI edit. If these services are genuinely separate and distinct, you can override with a modifier, but you need to document that in the medical record. These, as I said, are governed and regulated by CMS, so it's going to be CMS that monitors the use of those modifiers. So an example of a PTP edit is the same physician performs a psychotherapy service and an E&M service to the same patient on the same day. NCCI is not going to allow the psychotherapy code 90834 to be billed with an E&M office visit code 99212 because there are separate add-on codes for psychotherapy that should have been added to that E&M code. This is one of those ones that cannot be overridden with a modifier. Medically unlikely edits, MUEs, once again define that maximum number of units that can be performed. These cannot be overridden with a modifier. They're always set in stone. An example of this is the same licensed independent social worker, an LISW, performs 2 diagnostic evaluations, 2 units of 90791 with the same client on the same day. NCCI will deny the second evaluation as it is medically unlikely that one client would need 2 complete diagnostic evaluations on the same day. And the reason why these are not overridable is that these have been determined by CMS and the AMA to be medically unlikely.